So. If we look at the location of bacterial infections, we've already said this, that bacteria have to establish a foothold on the mucosal surfaces first of all, and that requires adhesins and other virulence factors. Some stay within the mucosa, and those we dealt with in the last lecture. In this lecture, we're going to look at pathogens that actually invade the tissues and are disseminated to sites distant from the point of entry. So, this kind of cartoon of a human as kind of Mr. Blobby with this alimentary tract and bits of respiratory tract and other things off it. Here what we're seeing is actual invasion into the body. So all that topology, surfaces and so forth, this is going beyond that and actually getting into the tissues. And these are the kinds of normally sterile sites that we would see infection under these circumstances in. So blood is normally sterile, cerebral spinal fluid should normally be sterile, fluid in your chest, abdominal fluids, pericardial fluids, bone marrow, joints should be sterile. And when these get infected, that's a big problem. So here we see the bacteria. This time, instead of staying in that mucosal surface, they've actually invaded and gone through it. They can get walled off. Sometimes they don't get very far. They're just in, say, subcutaneous tissues or submucosal tissues, and they form an abscess. With the disease tuberculosis, we have a thing called a granuloma formed there. They can spread through the lymphatics. They can spread through the bloodstream. When they do that, we call that bacteremia. Some bacteria can even hitch a ride inside phagocytes. So they're capable of living inside macrophages, and they'll travel around the body inside macrophages. So when we're looking at pathogenesis, just to remind you again of the kinds of factors that contribute to pathogenesis of bacterial infections, we have adhesins, fimbriae, these kind of hair-like adhesins, surface or outer membrane proteins, capsules that enable the bacteria to resist phagocytosis, and they also contribute to a phenotype we know as serum resistance. So if we take many different bacteria and we inject them into your blood, they will get killed very quickly, most of them, because you have all these factors waiting to pounce on them, if you like. So the complement pathway, antibodies may come along and opsonize them and so forth. So, but when they have a capsule, that actually goes a long way to overcoming that. Lipopolysaccharide we've spoken about before in gram-negatives, that can contribute to serum resistance and also trigger this septic shock and inflammation, and then various enzymes and exotoxins. Now in this talk we're going to focus in just on four, very quickly cover four bacteria which we might call invasive, which actually cause diseases in deep tissues. So Neisseria meningitidis, which causes meningitis, as its name suggests. We sometimes call this the meningococcus. It can infect the bloodstream. It can then spread to the lungs, cause pneumonia, can cause joint infections and various other things as well. Streptococcus pneumoniae, pretty much the same in terms of the spectrum of infections that we're seeing in terms of bacteremia and pneumonia as well. But it can also cause meningitis. So actually there's a mistake on this slide. I don't know how that's happened, but I'm talking rubbish here because Neisseria meningitidis doesn't cause pneumonia. I've obviously cut and pasted across from somewhere there. I'm just reading this without even thinking. No, Neisseria meningitidis can cause joint infections, but it doesn't tend to cause pneumonia. That would be vanishingly rare. Staphylococcus aureus causes soft tissue infections and spread via the bloodstream, and TB is a lung infection. So let's now focus on meningitis. What do we mean by meningitis? Well, the meninges are the linings of the brain, the central nervous system, in fact, of the spinal cord as well. There are three of them, but we don't need to know the details there. They form this set of protective membranes. And when they get inflamed, this is what we call meningitis. Meningitis doesn't actually have to involve infection of the substance of the brain. It is usually confined to this, what we call the subarachnoid space, the space under one of these meningeal membranes. But what happens is you get increased pressure in the cerebral spinal fluid, this increases pressure on the brain stem, and in the extreme cases, this leads to what we call apnea. People stop breathing, that means just not breathing, and death. Now, meningitis is not invariably fatal. Viral meningitis is actually quite common and resolves spontaneously. It takes a few weeks and then the patient gets better. Some meningitis, though, is actually life-threatening and can cause serious neurological damage. And so because of that risk, when we see a potential case of meningitis, we have to be very, very careful. We get the diagnosis as quickly as we can. We get the treatment in, correct medical care as quickly as we can. Just to show you that meningitis is no respecter of persons, here's a news item from a few years ago. Posh Spice Victoria Beckham actually got struck down by a form of viral meningitis. Now, those of you who are still awake after your lunchtime might be questioning how is it that someone with no brain can actually get a brain infection. I'd hasten to add that her husband is entirely immune to meningitis. So when we look at meningitis, what do we see? Well, almost all of them, 87% at least, start with a headache. And then there's this classic triad of diagnostic signs, a stiff neck, a fever, and altered mental status. So the person starts to become drowsy and confused. And you can see this little, I don't know if you've seen this particular pamphlet. It was a pamphlet that used to be given out to students a few years ago, pointing out that many of these are the same kind of things that you might wake up with on a Sunday morning with a hangover. It's important not to confuse meningitis with a hangover. Someone looks a bit odd, they're behaving strangely, they've got a headache. Well, maybe it's not a hangover, maybe they've got meningitis and you need to look out for them. Other signs that we see, sensitivity to light, so-called photophobia. They like to be in a dark room, they like to be in a quiet room as well because they're sensitive to sound. They get irritable, delirious, they can have seizures. These are the signs we see in children, adults. In babies and infants, obviously it's much harder to actually elicit what's going on. And you can actually see swelling. When the fontanelle is not closed, you can actually see this bulge appearing in infants from 0 to 6 months. And one of the most important hallmarks of the most serious form of meningitis is that you get a rash as well. And we'll say more about that in a moment. So in bacterial meningitis, we've got the headache, fever. We also get vomiting, drowsiness, photophobia. And then if it's meningococcal, caused by Neisseria meningitidis, we get this rash. And there's this so-called tumbler test, which you can do. So if you take a glass tumbler like this and hold it up against the rash, push it up against the skin, the rash doesn't go away. Most rashes, if you say had German measles or something else, that rash would actually blanch as you applied the tumbler, but here it doesn't because it's actually the result of bleeding into the tissues. If you like, it's a bruise, a small bruise inside the tissues. We've got a bit of redundancy there because we already mentioned infants. And neonates show often respiratory distress. They find it difficult to breathe. They're breathing quickly when they have meningitis. Now, we're kind of jumping about a bit here because I have to keep introducing terms, making sure that you're getting the jargon as we go along. So, a lot of the time when we have meningitis, we also have bacteria spilling into the blood. So the blood is normally sterile, and when we get bacteria in the blood, that in itself is called bacteremia. When we get bacteria in the blood which are actually causing disease, where we're getting signs and symptoms, or where there's reasonable evidence that they're actually multiplying in the blood, we call that septicemia. And so someone who has a pneumonia, someone who has meningitis, we will expect to see the bacteria spilling into their blood as well. So if someone's got meningococcal disease, taking a blood culture is a very sensible thing to do, as well as trying to sample the CSF. We see what we call metastatic spread of infection through the blood. So if these bacteria are whizzing around your circulation, every now and then they might get deposited somewhere. We also have, once the bacteria have established themselves and are growing in your blood, they trigger what we call systemic inflammatory response syndrome, or sepsis syndrome. So basically your whole body starts reacting to these bacteria. You end up with a fever, white count goes up, the heart rate goes up, and in fact the blood pressure usually will drop as well when these things get really bad. So what's happening with fever? So what happens to trigger fever in these kind of patients is we get macrophages and neutrophils acting as phagocytes. These are two main kinds of phagocytes. These are phagocytosing microorganisms. They release a protein called interleukin-1 into the blood, and then this then acts on a particular center in the brain, thermoregulatory center in the brain, and changes the setting, if you like. So it kind of changes the thermostat so that your body temperature, instead of being at its normal 37, goes up a few degrees. And it does this by reducing the peripheral blood flow, which is why you go pale when you're actually severely ill, and increasing heat production starts shivering, and you get what we call rigors, these attacks of very intense shivering, and the temperature rises. As we said, in the worst cases, we have this thing called septic shock, particularly endotoxin from gram-negatives, but sometimes other bacterial products. We see it also with gram-positives as well. You get this fall in blood pressure, dramatic fall in blood pressure, and what that means is that you then get a loss of blood flow to some of the vital organs. So someone who's had septic shock, they may start to then develop renal failure. Their kidneys start packing in. They may develop liver failure because there's just hypoperfusion, as we call it, of these organs. Now let's get back to meningitis. So easiest way to remember the most common bacteria that are importantly associated with meningitis, in this country at least, is to call them the NHS bacteria. So we have Neisseria meningitidis, the one we mentioned already, the meningococcus. This is causing disease in children and young adults predominantly. Pretty much always, this is always penicillin sensitive. Haemophilus influenzae causes disease in young children. There's a new vaccine that came out, well, this is an old slide, came out about 15 years ago, but it's new to me anyway. It feels new. These are often producing beta-lactamases. And then Streptococcus pneumoniae, this occurs at the extremes of age in the very young and in elderly people, and is sometimes penicillin resistant. Tends not to spread from person to person. The other two do that quite readily. Let's now focus in again on Neisseria meningitidis. So what kind of bacterium is this? This is a gram-negative bacterium. It lives inside cells. So if you look on this top picture here, you can see all these cells here. What you're seeing there are neutrophils or pus cells, and the reddish blobs are the nuclei of those pus cells. And in just a couple of them there, you can see all these stippled dots sitting over the top of them. Those are the meningococci actually living inside the neutrophil. And so that's why we call them intracellular. And then if you actually zoomed in even further, you'd see that they actually are coming in pairs. So that's why we call them diplococci. And the term coccus refers to the fact that they are spherical. So gram-negative intracellular diplococci. Now this organism colonizes the nasopharynx. So nasopharynx is just a fancy word for the back of your throat, particularly the part behind your nose. And there it doesn't do anything. And in fact, in this room here, probably an appreciable number of you are carrying Neisseria meningitidis. But it doesn't cause any inflammation, doesn't cause any disease, doesn't cause a throat infection. It just sits there, chilling out. And the carriage rates, if you sample the population, 10% up to 40%. There was actually a famous study done by a collaborator of mine, Del Aldine, in Nottingham, where he took Nottingham students and he showed that when they started at university in the first year, the carriage rate of meningococci went up. And that was largely because they were probably sharing saliva, which is the sort of thing that students do with each other in their first few weeks and months at university, and that was why the meningococcus was becoming much more prevalent. There may have been starting smoking and other things that contribute to meningococcal carriage as well. Now, in probably 999 cases, certainly 99 cases out of 100, maybe 999 cases out of 1,000, the meningococcus just sits there and does nothing. But in rare cases, these bacteria become invasive, and they infect the meninges and they cause meningococcal meningitis, or they infect the bloodstream and cause meningococcal septicaemia. And this image here is what you sometimes see in the most severe cases. So that rash that we saw earlier, that's called a petechial rash. That's a sort of where you get this little bit of bleeding into the tissues. Here you can see where that actually runs riot and you get real destruction of the tissues from this process, and patients like this may actually end up having to have an arm or a leg amputated as a result of the damage that's caused. So how does the meningococcus do all this? Well, it has a capsule, as I mentioned earlier. It has this outer layer that encapsulates the bacterium, formed from polysaccharide, and that's protecting it against phagocytosis. In fact, there are different kinds of capsule, different serogroups, depending on the kind of capsule they have, precise chemical makeup, the cross-reactivity they have with different antibodies and so forth. The serogroup B meningococcus is a particular nuisance, a difficult, hard target, because it makes a capsule that mimics a host epitope. It has a capsule made of sialic acid, and there are sialic acid residues on many of your cells, on the surface of many of your cells, and so we can't make an immune response to that capsule. And if we did, if we forced you to break tolerance to that, then we actually might induce autoimmunity. So for many of the kinds of meningococcus, we can actually have a vaccine based on the capsule, but not this one, the group B meningococcus. Lipopolysaccharide, LPS, also important. This is the endotoxin. This gets released, you get blebbing off of the outer membrane, and that endotoxin produces septic shock. So endotoxin is a key component of meningococcal sepsis. And then, like I said in a few minutes ago, we have this idea of serum resistance. So the meningococcus is able to live in the blood. Most of the things that live in your throat, if they get into your blood, they get killed very quickly. Similarly, excuse me, if you scrub your teeth, a lot of bacteria from your mouth get into your blood, but they all get mopped up and killed very quickly. The meningococcus is rather special because it has this ability to survive in the blood. So it has these pili, which allow it to attach to the nasopharynx. It has a specific protease, an IgA protease, which cleaves the particular kind of immunoglobulin that you see in body secretions, in saliva and so forth, and it cleaves that on the mucosal surface. Another key feature of meningococcal infection and the pathogenesis of meningococcal infection is the ability of this organism to kind of change its coat, if you like. It can undergo what we call antigenic and phase variation. So it can change the surface structures that are deployed to the outside world, that are seen by the immune system in a very dynamic way. And this involves the capsule, LPS, surface proteins, pili, and it allows the organism to avoid the immune response. So you start making an immune response to one surface determinant, it switches to having another one. So this is just showing you graphically what I've just said in words. So you have here the cytoplasmic membrane, the periplasm, the outer membrane. You've got the lipo-oligosaccharide. In fact, this is being quite technically correct because unlike, say, E. coli, where you have these very long side chains on the lipopolysaccharide, here you have much shorter chains, so it's actually called a lipo-oligosaccharide. We have these pili, we have the capsule, we have outer membrane proteins, and so on. So this antigenic variation I mentioned, how does it come about? Well, what actually happens is that we see changes in the DNA sequence, changes in the genome of the bacterium. So it's got this very volatile genome, if you like. And this results in changes in the amino acids that make up surface proteins. So the pili, these hair-like appendages that allow the bacterium to stick, they can change a lot. But it also, these changes in DNA sequence can make changes in the pathways that synthesize non-protein components. So that the lipo-oligosaccharide component, that you can have different sugar moieties deployed on the outer surface as a result of these changes in DNA sequence. And so this is basically changing the epitopes that the immune system's seeing. It evades the immune response. And in a sense, it's driven by a kind of Darwinian selective pressure. So if the body starts making an immune response to a particular epitope, it will wipe out the 99% of the bacteria that are carrying that one. But because the bacteria are always changing in the background, there's a small part of any population that will have changed its surface. Those then are selected for, they grow up and become the majority population. Okay, so that's the meningococcus. We mentioned Streptococcus pneumoniae, which is another important cause of meningitis, bacteremia, and this one does cause pneumonia, unlike the meningococcus. I don't know how that mistake got in there earlier. So the meningococcus and pneumococcus, these are so familiar to us as medical practitioners, as people working in labs, that we have these little pet names calling them meningococcus and the pneumococcus. The formal Latin name for this is Streptococcus pneumoniae. Again, this lives in the throat, found in the nasopharynx of an appreciable number of children, 20 to 40%. But it also causes meningitis. It can cause community-acquired pneumonia. So it's the kind of a pneumonia that you'll get out there in the outside world, not in hospitals, but if someone gets a bad pneumonia, particularly at the extremes of age, a 75 or 80-year-old gets a pneumonia, this is the sort of thing they'll get it with. It can cause a bacteremia, and it also can sometimes contribute to what we call otitis media, where you get infection inside the ear. Now, this is also a diplococcus. It comes in pairs, but this is a gram-positive diplococcus. And there in that gram stain, you can see that it is, this time it's not intracellular. You can see those little dots of pairs there lying all over the place. They're not actually an association cells. You can still see some pus cells there, but they're not particularly in association with them. And actually, it has a very particular appearance when we grow it in the lab. If we grow it on blood agar, it lyses the blood, so we put some blood in the agar, it lyses it, but doesn't completely get rid of it. It just turns it this kind of greenish colour. And the cells in the middle of the colony start to lyse, undergo what we call autolysis. And so you get this sunken centre. And in the UK, we call those draftsman's colonies, because they look a bit like the ones that you play drafts with. So how does Streptococcus pneumoniae cause disease? What are its virulence factors? Well, surprise, surprise, it too has a capsule which allows it to resist phagocytosis, like the meningococcus. But this organism is a lot more variable than the meningococcus in terms of its capsular profile. There are over 90 different kinds of pneumococcal capsule that have been described, structurally and serologically distinct. And again, there is phase variable expression going on. So this thing is changing its capsule in a population. There's a molecule called teichoic acid that sits in the cell wall. That is signaling to the immune system. That may be responsible for some of the features of septic shock that you would see if someone had pneumococcal septicemia. And then there's a whole range of surface and secreted proteins. So this is a gram-positive bacterium, and if you remember from lectures you've had before, in the gram-positive bacterium there's just one membrane, the cytoplasmic membrane, and then everything that's coming out of that is on the surface, associated either with the membrane or with the peptidoglycan layer that sits outside the membrane. And so there's a range of them here, things that are binding choline. There are exoenzymes like this hyaluronate lyase, breaking down one of the components of the tissue matrix, hyaluronic acid. Similarly with neuraminases, they breaking down this neuraminic acid. Then you've got the same pili and IgA proteases, just like we saw in meningococci. There are two interesting additional toxins, virulence factors that we see in the pneumococcus, something called pneumolysine, which appears to be associated with virulence. It's one of a particular group of what we call cytolysins that will actually lyse macrophages and other kinds of cells. And then there's this autolysin, which actually breaks open the pneumococcal cell. And it appears to get, to be able to get the pneumolysin out, the autolysis has to occur using this autolysin. So the cells are sort of some way committing suicide. That at least is the prevalent view. I think there are some dissenting views that maybe pneumolysin is actually actively secreted. Anyway, it's a bit dry talking about it as words. Here's a picture showing the same kind of thing here. You have the pneumolysin being released as the cell is lysed by this lit-A protein. You've got various proteins anchored to the cell envelope there, stuck onto the peptidoglycan. I'm not going to go into the details of all the others there because I think it's not appropriate at this level. Okay, before we move on from meningitis, let's just pause for a second to think about vaccines against meningitis. And this is an area where we've actually had a considerable amount of success in medical science. The so-called Hib vaccine against Haemophilus influenzae, one of the three that I haven't mentioned in any detail, this actually worked very well when it was brought in about 15 years ago. About 10 years ago, a new conjugate meningococcal group C vaccine was brought in, and I would hope that everyone in this room has had that vaccine as well. That targeted the group C meningococci, which accounted for about 40–50% of meningitis and before the vaccine was brought in. There are other vaccines available. The meningococcus serogroup A is particularly associated with sub-Saharan Africa, sometimes seen people returning from the Hajj when they go on the pilgrimage to Mecca. They bring those kind of meningococci back, and there are vaccines available for that. There is also a pneumococcal vaccine as well, which initially there was this 7-valent vaccine that included capsules from the most common capsular serotypes. Now that's been expanded to the 23-valent. There's a question about how efficacious that is in very young children, but that has been rolled out and it's given to old people as well, offered to those over 65. And just to show you that back, it was over 10 years ago now, but you can see what happened when they introduced the meningococcal C vaccine, the serogroup C vaccine. If you look at the cumulative number of cases so you can see from 1997 to 98 in green there, 98 to 99 in red, and then when they introduced the vaccine in the year 1999 to 2000, suddenly there was this tailing off of meningococcal disease and effectively a halving of the infection. So we still have a problem with group B, meningococcus. We can't get a capsular vaccine for that, but we have at least in the last 10, 15 years made big progress there with that. Also, before I leave meningitis, just to stress that this is actually a kind of medical emergency. And most of the time when we're looking at infections, we want to get a good diagnosis. And particularly microbiologists fuss a lot about get the right specimens, do it all right. Here, it's such an important disease, it progresses so quickly that we abandon that rule and we say just get on and treat this patient and sort out the diagnosis and the minutiae of the diagnosis later. So general practitioners will actually carry in their bag some benzyl penicillin, which they can give immediately. If they do, say, a home visit and they see a patient, they can immediately give an injection. And then we give these broad-spectrum cephalosporins and then rationalise that. So when we don't know what the cause is, it might be meningococcus, it might be something else, we give a much broader spectrum antibiotic and then we narrow that down over time. And chemoprophylaxis, again, this is one of those jargon words, that means giving treatment to prevent an infection, not to treat an infection. We do that for what we call kissing contacts of meningococcal infections. So if someone has meningococcal meningitis, they go to hospital, they will have someone from the public health service will go and trace who they've been close to. So maybe the very close people in their family, siblings, that sort of stuff. If they're one of you, it might be the people that, so-called kissing contacts, boyfriend, girlfriend, maybe flatmates as well, but maybe not. Staphylococcus aureus. So, moving away from meningitis now. This is, I have to keep throwing jargon at you, I'm sorry, but that's the nature of any subject. There is things you have to learn. This organism, we describe it as catalase positive, forms gram-positive cocci in clusters, and Staphylococcus aureus is what we call coagulase positive. And there's a whole heap of other staphylococci that we call coagulase negative staphylococci, much less important in terms of disease. Staphylococcus aureus is public enemy number 1 when it comes to staphylococci. And again, just to show you this visually, if we look down the microscope at some staphylococci, they are, as the name suggests, they are coccoid, they are spherical, but they clump together in these grape-like clusters. So the first generations of microbiologists, when they looked down the microscope, they saw these clusters and they thought of grapes. I mean, it's a bit bizarre that people think of food when they're looking at these kind of pathological specimens or whatever, but that's what they did. So, in fact, that's where the name Staphylococcus comes from the Greek for grape. To actually identify it in the lab when it's growing, if we see a gram-positive coccus and we want to be certain it's a Staphylococcus rather than a Streptococcus, we apply some hydrogen peroxide and it fizzes away. And this is a sign that there is this enzyme catalase being produced. And then once we've got to that stage, we do this coagulase test. So we grow the organism, incubate the organism for a short while in a broth containing plasma. The bacterium will produce citrated plasma, so the plasma won't clot spontaneously, but this organism, Staph aureus, produces a coagulase enzyme which forms a clot under those circumstances. And Staphylococcus aureus is the coagulase positive Staphylococcus. So it probably, I know maybe even half of you are carrying Staphylococcus aureus in your nose. You're carrying it in the part of your nose that you pick. It's called the anterior nares, this bit up here where you stick your finger, the bit where you can stick your finger in. And it also can be carried on the skin, on the hands, particularly in hospitals. If a nurse goes to one patient who's got Staph aureus on their skin and then actually takes their blood pressure or whatever and then goes to another patient, it can spread on the hands of the healthcare worker. Now, Staph aureus is what we call an opportunistic pathogen. It only causes disease where there are breaks in the skin. So if I smeared Staph aureus all over your skin, it wouldn't do you any harm. If it's in your nose, it's not doing you any harm. But if it gets into your, under the skin, into the subcutaneous tissues, then it starts to run riot. Even there, it's not always a dreadful disease. You get a range of superficial infections. They may even resolve without treatment, but certainly will respond to treatment. Then you get more serious infection in a minority of cases. And the common feature that we see is a process known as suppuration, which is the formation of pus. So basically the Staph aureus cools down all those neutrophils into an abscess or into the tissue, and you get the formation of pus. Typically causes wound infections in hospitals. So if anyone has had an operation in a hospital, the one thing to worry about is that they're going to get a staphylococcal infection, a wound infection with Staphylococcus aureus. If it gets onto what we call foreign bodies, things like intravascular devices, joint prostheses, bits of plastic or bits of metal that's stuck in the patient, artificial heart valves, then it really can wreak havoc. So here are some of the what we call local pyogenic infections. Pyogenic is just another word for pus forming, and there are a range of these that you can see here. Just depends on quite where they are on the body and what tissue planes are infected and so forth. So we have impetigo, folliculitis, carbuncles, abscesses. An acute paronychia is where you get infection around the nail bed, and you can get cellulitis, surgical wound infections, where you get this spreading of this red and angry area around a wound, or here there's a leg abscess, a leg ulcer that's actually been infected. Staph aureus, once it gets into the blood, then can travel around the body. So it may get into your subcutaneous tissues, then spreads into the blood, and then it can cause this subcutaneous disease elsewhere. One of the most difficult to treat infections is where you get osteomyelitis, where it gets into the bones. And particularly if someone's got abnormal tissue there, so they've broken a bone, they've had major trauma, maybe they've had pins in there to fixate something, that's the kind of place where Staph aureus will cause big problems. Heart valves. If Staph aureus gets onto a heart valve, it can chew its way through a heart valve pretty damn quickly. Other causes of endocarditis usually require there to be some kind of existing or abnormality there, whereas Staph aureus, if we injected Staph aureus into your blood, it could chew through your heart valves pretty quickly. It can get into the brain and cause brain abscesses as well. So how does it do all this? Well, it's got a cell surface decorated with these numerous things called microbial surface components recognizing adhesive matrix molecules, M-scrams. And these are basically kind of proteins sticking out from the surface of the bacterium. Here, and they have various things they bind to, you can see listed here. Some of them bind, protein A binds to immunoglobulins, some of them bind fibrinogen, some to collagen and so forth, and mainly matrix proteins. You've got these exoenzymes, like coagulase, which forms clots. You've got another thing called staphylokinase, which degrades clots. All of these are causing damage in the tissues. You've got a range of exotoxins in specific strains. Some of them are listed there. Exfoliatin is a particularly nasty one. It causes this infection called scalded skin syndrome, which you can see here. A child with this kind of syndrome appears in the casualty, and immediately the parents get accused of chucking a kettle over the child or something, but in fact it's an infection caused by Staph aureus releasing this toxin, which causes the outer layer of the skin to lift off. There's also something called toxic shock syndrome toxin, which causes, as its name suggests, toxic shock. The patient gets really sick, blood pressure drops, fever, myalgia. And this was initially described in association with tampons. So it sometimes used to be called tampon shock syndrome. The Staph aureus could actually colonize the tampon. Now all the tampon manufacturers have come up with formulations that avoid that from happening. So it doesn't happen now, so don't worry about it. But it used to be a problem 30 years ago or so, this first surfaced. You might have heard of MRSA. MRSA is a variant form of Staph aureus, which is resistant to antibiotics. MRSA stands for Methicillin-Resistant Staph aureus, but that's a bit of a quirk of history because we don't actually use methicillin to treat Staph aureus in this country, but basically MRSA is resistant to all the beta-lactam antibiotics, penicillins, cephalosporins, and so forth. And so it's a particular problem because it's very difficult to treat these MRSAs. Instead of using cheap, readily available antibiotics, you have to go for things that are much harder to give and are more expensive and are more toxic as well. Right, last 5 minutes on tuberculosis. So tuberculosis is an infection of the lungs. Most of the time when you get tuberculosis, it's asymptomatic. During someone's lifetime, if they have infected with tuberculosis, about 10% of them will get on to have active disease. And it's a big player on the world stage. There are millions and millions of cases, millions of deaths every year. And I've just put up here to show that there has been progress in medical science. Muhammad Ali Jinnah was the founder of Pakistan. He, within a year after Pakistan gained independence, he actually died from tuberculosis because at that time we had no effective treatment. The treatments were just coming in. The first trial was done just as he was dying. If you fast forward a few decades, Nelson Mandela actually had TB as well, but by then we had treatments for it, and he was treated and then went on to actually serve a full term of 5 years as the leader of his country. It's interesting to speculate what would happen if Jinnah had actually been able to have treatment for his TB. TB is a very difficult organism, different organism from others. It's got this very complex cell wall, it's resistant to common antibiotics, grows slowly, lives inside cells. And tuberculosis is also a disease apart because you have this very long course. You have primary infection, which may not have any symptoms at all, or you might get a bit sweaty and a bit of fever. You sometimes get what we call night sweats, where you sweat at night and soak the sheets. Typically, it's in the lungs. You can get tuberculosis from drinking milk that's, say, contaminated with a bacterium. It can sometimes, in rare cases, get actually implanted in the skin. But after that primary infection, it sort of seeds to the local lymph nodes, starts causing problems, but then usually it just goes latent. And then maybe decades later, it's suddenly reawoken. So you might get infected as a child or as a young adult and only actually develop clinical tuberculosis when you're in middle age or old age, many, many years later. So TB goes into the lungs, you get these cavities form in the lungs of those people who have pulmonary tuberculosis. In a small number of individuals, you get also tuberculous meningitis, so you get this TB going into the meninges, but that's quite rare. Typically, it's a disease of the lungs, and you get cavities forming in the lungs. And we have these features, the ones I've already mentioned, fever, malaise, weight loss, night sweats. You get cough, you get something called hemoptysis, which is a fancy way of saying coughing up blood, and you get chest pain. And when we look down on the X-ray, we can see certain features. We can see these opacities up in the upper zone there. You can see on that chest X-ray there, there's a region there that looks cloudy and then a clear region in the middle of it and so on. And you get cavities forming. Anyway, I'm starting to run out of time. So when we want to stain this, we don't use the Gram stain. We use something called the Zeal-Nielsen stain. I'll say more about this in a later lecture, and we grow it on specific slopes. In terms of virulence factors, there's a lot known, but we still don't really understand it all. They have a very thick, complex cell wall. They live inside macrophages, and they cause a particular lesion known as the caseating granuloma, which has a characteristic picture down the microscope. Treatment is very difficult. We have to use multi-drug treatment, and we have to give treatment for months. It's not like if you have a urinary tract infection, take 2 days of antibiotics and you're better. Here, you have to be treated for a minimum of 6 months to be cured of tuberculosis. So it's a big, big problem. And that's me finished. So I've just taken you through Neisseria meningitidis, Streptococcus pneumoniae, Staph aureus, and briefly through M. tuberculosis. Thanks a lot.